Great. So hi, Jeremy. Welcome to the Big Unlock podcast, and it is great to have you as our guest. We are hoping for some exciting interaction to share with our audience. So I'm Rohit Mahajan. I'm the CEO and managing partner for Demo Consulting and Big Rio. And as you might be aware, we've done over 150 of these. So I think we are coming up on the 152nd episode of the Big Unlock podcast now. So with that said, please, would you like to introduce yourself?
Absolutely. Well, first of all, Rohit, thank you very much for the opportunity to come and talk to the Big Unlock podcast and all of the members that are listening out there. I appreciate it. My name is Jeremy Cauwels. I serve Sanford Health out of the Upper Midwest as their Chief Medical Officer and have for roughly the last 5 or 6 years. Prior to that, my role was in direct patient healthcare, and I was a hospitalist at the Sanford USD Medical Center in Sioux Falls, South Dakota, where I still currently live. As Sanford, we cover roughly 425,000 lives from a health plan standpoint, 2.4 million lives from the standpoint of the people that live in and around us.
Wow.
We cover a landmass that goes all the way from Wyoming east to Wisconsin and even the upper peninsula of Michigan. In those states, we're primarily headquartered, and our largest medical centers are actually found in South Dakota and North Dakota, both affiliated with the universities there. As well as recently an acquisition in the Marshfield Clinic for additional clinic sites in and around Marshfield, Wisconsin. So that's been an excellent add for us from a system standpoint. We have 56 hospitals, 270 plus clinics, 144 senior care communities, and right now 4,500 physicians and advanced practice providers. So a big group. I used to be able to say we covered a landmass the size of Texas for a comparison. We are now larger than the size of Texas.
Wow, that's amazing. And in the rural setting too, Jeremy. So that makes it even more challenging in terms of being able to reach the patients and being able to serve them in such a setting, right? Where you're covering such a rural areas.
Absolutely. So if you think about the Dakotas, you think about Western Minnesota, you think about Northern Wisconsin, all of those areas are noted for relatively small towns and communities, a lot of open space between people, generally farming communities or rural communities or ranching communities, those sorts of things. So it is not unusual for us to deal every day with patients that may have to drive an hour or 2 hours to see their doctor and potentially even farther to see a specialist. So
wow, that's amazing. That's amazing. So Jeremy, please tell us more about how you ended up on this side of the technology side of the things. You started, as you said, as a physician and practicing. So what attracted you or what motivated you to this side of the house?
So for me, it was really about how do we reach patients?
Yeah.
What I wanted to learn very quickly when I got into this role was what can technology do to help us with things that have always been difficult stumbling blocks in the Midwest? What we know is that many of the counties that we live and work in are considered healthcare deserts. Even more of them are considered mental health care deserts. What we know is it's impossible for many families to take a full day off of work to drive to the doctor's office, have a 15-minute appointment, and then drive back home, especially for single-parent families or for other places where making ends meet every day is the primary concern. So what got me into this was the idea that we could provide virtual care to patients and meet them where they lived. And rather than the old phrase of your doctor will see you now, we like to think of it as the patient will see us now.
That's beautiful. That's a great flip.
Transition.
Yeah, that's a great flip. So talking of all things digital and you mentioned telehealth and telemedicine as well. So what are some of the digital initiatives that you have looked in the past? What are you looking to in the future? Jeremy, if you can share with us that how this digital front door or how this digital approach is likely to increase the access to patients.
Absolutely. So thankfully, Sanford has been blessed with philanthropic support dollars that have been earmarked or dedicated to improving our digital health footprint. So
Awesome.
with that, we're able to expand. We actually just opened our virtual care center. Our virtual care center is a standalone building outside of our hospitals that focuses on how we use technology in order to better reach our patients. In that, you can find everything from 3D printed models that physicians can use to understand anatomy before they have to understand the anatomy. And more importantly, virtual connections where we can not only have physicians seeing patients, but more importantly, we are an educational organization as well. We have 300, pushing towards 350 residents and fellows in our organization at all times. And so the ability to teach some of those folks a webside manner instead of a bedside manner, and get them to be comfortable in a screen just like you and I are talking today
Very
is,
cool.
is critically important.
Yeah.
And so we use that education institute and what we call the innovation hub, aka a safe space where you can try things digitally that you wouldn't otherwise be able to try on a patient encounter,
Right.
and are able to move that forward. The other part is actually we house a fair bit of our clinical operations for virtual in that building as well. So that, for lack of a better word, if you're going to do this, you want to know where your IT resources are. So if something isn't going the way it should, it's easier and smoother to move. And they've done a wonderful job of putting those resources at our fingertips in that same location.
That's awesome. That's awesome. And what do you think, Jeremy, of, you know, in any podcast, AI and Gen AI
Oh,
is
sure.
is not avoidable to bring up. So obviously I bring it up and would like to ask you what are your thoughts around that? Have you been using any traditional AI, and now more generative AI in any of your innovation project initiatives?
Absolutely. So one of the things that we've talked about and looked at from an AI standpoint is how do we make a physician more efficient in finding the information that they already could find if they had nothing but time to pore over the electronic medical record. And what I mean about that is we've already published information to the American College of Gastroenterology about the fact that our computer can come up with 85 things that affect your risk for colon cancer. And it can literally score you and tell you the difference on why Jeremy's risk for colon cancer might be different than Rohit's. As we do that, knowing that the upper Midwest is a higher risk area for colon cancer, and it's also a higher risk area for people not coming in to get appropriately screened, we've been pushing forward to say, we want to get the evidence base we need. We want to roll out a prospective study that proves that this works so that we can build a better mousetrap for healthcare in general, helping doctors understand when they look at a patient that the screen right next to them tells them Jeremy's a little bit higher risk, and we may want to be more aggressive in our screening than we would for somebody who's at lower risk. The other things we have done in doing that, as you're probably aware, the U.S. PFTF, Preventive Services Task Force, changed the screening age for colonoscopies, or screening age for colon cancer, sorry, a couple of years ago to go from 50 to 45.
I see.
What that meant in the Dakotas and in the upper Midwest is we had 100,000 people that yesterday didn't need a colonoscopy or didn't need to be screened, and today they all need to be screened. And so we very much went into, in addition to bringing a patient in for colonoscopy, which may be very difficult, how do we do things like reach out with stool-based testing and that sort of thing to be able to reach them in their home? And, as you can imagine, whether you live in Howard, South Dakota, which is a little town of 848 people, they're used to getting Amazon. They know how that works. And so if you can put a box at their door that allows them to keep up with their healthcare, you're going to be moving them ahead as well. And so we've worked very hard to say we want to bring all of those programs in to help those patients at normal risk according to any scoring system that's officially currently part of the system, but also to understand, because of who we are and because of all the data we have on our patients, who's a little bit of normal risk and who's a lot of normal risk.
I see. I see. Just a curious question coming to my mind on this, Jeremy, is there a very diverse patient population speaking many different languages, or is it pretty homogeneous? How does it look like when you do the population health analytics?
So interestingly enough, we have
Mm.
more diversity than people expect in the upper Midwest.
Mm-hmm.
The largest, if you will, ethnically diverse group is Native Americans. And
Okay.
in some of our regions, the three counties around some of our hospitals are all Native American land. In South Dakota alone, 3 of the poorest counties in the United States are found on Native American land. And so all of those have, difficult areas
Yeah.
that we have to work through. I will also say that one of the communities we work in on a regular basis speaks 57 different languages because there's a large proportion of that town and that county that's supported by the meat packing industry. And
Wow.
so many places, and we have several like that around this area, have different ethnic pockets of folks that absolutely, need to be served and need to be taken care of, regardless of their ethnic background, regardless of the language they speak, and regardless of, what the best way is to reach out to them. How do we find the way that works for them?
Yeah, absolutely. And again, a curious question, because we work with one of our clients is one of the largest telemedicine companies, and we saw a huge spike during COVID on telemedicine visits to the tune of 8,000%, right? And then it has kind of, people have gone back to normal and COVID is getting to be forgotten.
Yes.
How's been your experience on the telemedicine visit side of things, given that, you know, the geography is such and the rural nature of the area?
So far, we've saved our patients roughly 33 million miles of driving.
Wow.
Uh, to put that in perspective, Mars at its closest point during its rotation is less
Yeah.
is that distance away.
I mean, imagine that.
Yeah,
And look at the carbon footprint saved.
right, exactly.
Yeah.
In addition to that, we've done now over 800,000 visits
Hmm.
virtually. 20% of our mental health visits every month are still virtual. 1 in 5 still choose to see their mental health provider on a virtual basis. Now, some of that may be due to the fact that you just physically can't find a mental health provider in
Yeah.
in your area. Some of that may be very much due to the fact that I drive a blue pickup, a blue Ford pickup is what I drive.
Hmm.
There are folks in some small towns that wouldn't want their blue Ford pickup to be seen at their psychologist or psychiatrist's office. That
Yeah.
stigma still exists. And so
Yeah.
giving them the option to see their doctor in a way that makes most sense to them is extraordinarily helpful.
That's great to know.
Yep.
So one other thought which I wanted to discuss with you, Jeremy, was that so there are three aspects that I'm kind of trying to think about together is that what are the patients looking for, what are the caregivers looking for, and what are clinicians looking for in some of these digital approaches that you are taking?
Absolutely. So the patient's looking for, you can see over my right shoulder here, I have 3 children.
Yeah,
Um, so those
lovely
patients
family.
are much younger. I will
Yeah,
tell you that my children haven't gone to an in-person medical visit in the last year, other than when they needed to for a sports physical.
I see.
If they feel ill, they set up a virtual visit. If they have a follow-up with a specialist, they do it virtually. What's great is that it allows flexibility of both the specialist and the patient, such
Yeah,
that my children have actually conducted medical visits while they're eating their breakfast at the kitchen table.
yeah,
So that is something that would be unheard of to my parents, who would
yeah.
still much rather drive than try to interact with their doctors on the phone. So as you talk about the patients, there is absolutely, those things. From a clinician standpoint, we've been lucky enough to use, going back to the AI just a little bit, use
Hmm.
some of that automated dictation technology that allows ambient
Yes.
listening. And
Yeah,
I will tell you that one of our busiest family practice docs converted over to the ambient listening. He sets the phone in between you and the patient. He doesn't have to look over here to find the
yeah.
computer screen. And not only that, but his notes are for the most part completed when he finishes his scheduled day at 5. He told me just
That's
the other
true.
day, not only did I finished my day at 5 o'clock. My notes were all done by 5:15. I made it home to have dinner with my family, which almost never happens. And I had enough extra time because I didn't have to do my notes, after I got done with dinner, that I actually took my daughter out to buy her first used car.
Amazing, amazing. I think it's true that ambient listening definitely is uh, turning out to be the top use case, for generative AI.
I
Mostly.
completely agree. And
Yeah.
obviously, I think it will grow and
Right.
to be what is the next use case. But as
Yeah.
far as the doctor-patient interaction, uh,
Hmm.
if everybody talks about good old days, however far back your good old days were.
Hmm.
But many doctors remember the time when you didn't have to be attached to the keyboard and you didn't have to be
Yeah.
things down. And this brings you back to that time where the most important thing is your interaction with the patient and your ability to talk back and forth. And whether that's through a screen like this
Yeah.
or one-on-one with a patient in a room, it's still a much more satisfying discussion for both the
Right.
doctor and the patient.
Yeah. That's amazing, Jeremy. So, Jeremy, what are some of the digital tools or new approaches that you're using for taking care of patients at home, including, let's say, remote patient monitoring and patient care at home and things like those?
Yeah, so one of the things that we rolled out in 2023 was a text-based
Mm-hmm.
patient monitoring tool. So literally, we can take common diagnoses, so things like diabetes, heart failure, depression. We actually use it also in people that have been discharged from the hospital to make sure they have
Mm-hmm.
rapid follow-up. And
Mm-hmm.
we can set up scheduled
Mm-hmm.
interventions from a text standpoint
Mm-hmm.
that allow the patients to feedback to us, even though they don't have to call, wait in line, or get an
Yeah.
appointment. I'm happy to say, and this is just one example, but we had a patient who had been seen in on one of our emergency rooms for depression. Horrible story that anytime somebody feels that depressed that the emergency room is where they have to go, but it happens every day all across the country.
Mm-hmm.
We sent her home with this monitoring, and about a week or two later, she actually replied on a scale of 1 to 10 that her mood was a 1. That set off an alarm for us. We were able to call her back. And it turns out she's a single mother at home being overwhelmed with what was going on in her life in general. And she had actually already written her suicide note.
Oh my God.
She
Yeah.
was going to end her life. And we were able to come around with her, get her into an appropriate appointment. And I'm happy to say it's now months after that, and her
Yeah.
young family are continuing to grow and thrive.
That's an amazing story. So I think as we are coming towards the end of our conversation, Jeremy, any other thoughts that you would like to share with the audience? Any news or
Uh,
any new initiatives that you're looking in this year?
Sure. One of the things I'd like to talk about as well, sort of dovetailing on the comment I just made about mental
Yeah.
health, is many of the places that all of us live are what I would call mental health deserts.
Hmm.
Uh, That term has been used, and it's described, roughly 95% of the Dakotas, 95% of our footprint is in a mental health desert. Um,
Hmm.
what we've done, in addition to the virtual visits that I talked about before, is
Hmm.
also making virtual psychiatry consults available to our emergency rooms. So that if
Oh,
you need to see um, a psychiatrist and
yeah.
you're in the type of situation where you're already in an emergency room, which is generally not a good time for anybody involved,
Yeah.
rather than waiting until morning, or God
Yeah.
forbid, waiting until you can be transferred to an open psychiatry bed, which could take
Yeah.
days, uh,
Yeah.
we are able to say we can pipe a psychiatrist directly into that emergency room that night or
Wow.
that day, have the conversation you need to have, find out what the appropriate follow-up is, and move
Yes.
on and do that with our partners who are a licensed psychiatrists and may not even be in the same city or state that you're currently in.
That's amazing, Jeremy. And that's amazing that we can do this, now with all the technology that is available to us.
It
So
is. It's
any other closing remarks?
No, I just want to say thank you. I want to say thank you for allowing me to come to tell the story just a little bit about Sanford
Of
and how we
course.
continue to reach out to our patients and try to, despite the distances, bring them as close to care as we can.
Thank you, Jeremy. Really appreciate it. It was truly engaging. I'll close the recording now and we can chat for a few minutes.
Sounds great.
Thank you.